Welcome to another edition of the Litigation Psychology Podcast, brought to you by Courtroom Sciences. Dr. Bill Kanasky coming at you, and part of our continuing MedMal series for early 2024, which we're very excited about. My guest today, Dr. Jeff Willis. Dr. Willis has a really unique job. And actually, I have not ever met anyone doing what he does, so I'm really, really excited to talk about his background, his current experiences. He actually works with both plaintiffs and defendants, which is unique, but I think probably necessary given what he's doing. So we're very excited to have him. Dr. Willis, thanks for being on the show.
Yeah, thanks a lot for having me. Yeah, please don't hold it against me that I work both sides. So
No, that's okay. Those plaintiff attorneys listen to this podcast. I know that for a fact. But we have a lot of defense attorneys, a lot of insurance claims people that listen, and so I think it's actually great because a lot of expert witnesses, right? If they're really going to have any credibility with the jury, they need to work on both plaintiff and defense cases, and so I see this as no different. So I think that's a good thing. So, so Dr. Willis, let's just kind of start with your background. Well, actually, let's do this. Let's talk about define currently exactly what you're doing, the services you're providing, which again I find very, very unique and fascinating. And then we'll kind of backtrack from there on your background, kind of how you got from there to here.
yeah, sure. So I do not do expert witness work. I'm not an expert witness. I'm not a testifying expert. So I work with both plaintiff and defense side, strictly on medical malpractice cases. And primarily what I do on the plaintiff side is a lot of pre-litigation, case merit analysis type work. So, they get, however many cases they come through their intake and they think, yeah, a few of these sound reasonable. They bring them to me, they send me the records, I take a look, and then I work with them on, is this a case worth pursuing or not?
Yeah.
And if it is, here are the experts that I would use, and here are the theories that I would use. And then I'm available later down the line too for deposition, line of questioning strategy, anything that comes up. On the defense side, obviously, you guys don't get to choose which cases you pursue because they're brought to you, right? So on the defense side, I simply, from a completely unbiased standpoint, help you understand the strengths and weaknesses of the case and where the holes are in the case that you don't understand, or that you might not recognize just based on these preconceived notions that you've built around your defense, or that your defendant or your defendant physicians have built around it.
Yeah, let's talk about that, because one thing I see, and we've written papers on this. I do speeches on this. In the psychology, we refer to this as confirmation bias, meaning we see a lot of defense counsel struggle to see their case objectively for a couple different reasons. Number one, their past experiences. Number two, their own inherent biases. Number three, maybe pressure coming from the insurance company or the hospital system, pushing, how they see the case. And that puts it, quite frankly, I think that I'm not blaming defense counsel. I'm saying they're put in a pretty tough position because I think to have success on a case, you need to be able to assess it very, very objectively with some blinders on. And I see that as a big challenge. Is that something that you assist with?
Yeah, absolutely. I mean, so the issue, I mean, you listed all of those people that are sort of giving them that confirmation bias to begin with, but you got to start at the heart of the matter, right? The physician that is being accused of negligence, right? Because that's where the first lie starts. When lies happen, right? That's where the lies start. And so your defendant physicians, they're lying to you. They don't know they're lying all the time, right? But they can certainly be lying to you because, as a physician, as soon as you hear of a bad outcome, right? And you know most of these bad outcomes before you're ever served. Like
Yeah.
you know, your colleagues talk, you know, you've glanced through records, you know. The instant that happens, and Bill, I mean, you're, you know, psychologist, you understand, the instant that happens, your brain starts building that story of
Oh
what
yeah.
happened and how I didn't screw up. Because
Automatically.
you have to,
Automatically. Yeah.
and you have to do it. It is a defense mechanism that you absolutely have to do. The number of times I mean, I've been a physician for 20 years, right? The number of times in my career where I've heard, hey, did you hear, hey, you know that patient you saw? Worst thing anyone can say to you when you show up for a shift. Hey, do you remember that patient you saw a couple days
Yeah.
ago? Like literally the absolutely worst thing you could ever hear. And instantly from that point forward, you are building a story in your brain of what happened that day when you saw that patient.
Yep.
It doesn't matter what your chart says. It doesn't matter what really happened. You start building a story, and that's how you remember it. And you're never going to remember it a different way, because it's that defense mechanism you have to have as a physician to be able to go ahead and go see the next patient. Because if you think you really screwed up, I mean, everything down the line is a mess. So when you start having those first conversations with your physicians and talking to them about what happened, about the case, and having them look at their charts, it is all through that lens of the story that they have already built in their head
Yeah.
around what happened. Sometimes it's dead on, but not very often. And as defense counsel, they have nothing to go on except what what the doc's telling them, and they have to believe it. But what I do on my end is I know what really goes on because I've done it for so long. Right? I've been in healthcare for 20 years, so I hear the story you're telling me, but here's probably a different version of what happened, or here are all the other possible versions of what happened, or here's what everybody else can say happened based on what the records show. So that's a lot of what I do for the defense.
Excellent. Well, I want to dive deeper into that, but let's backtrack. Tell me where you went to undergrad, where you went to med school, your training, any clinical practice you have, and then how it kind of led you to get to here. Because I was kind of in you and I may have a similar story. You know, I'm on this, you know, clinical academia track to go end up at a major university and healthcare center. And then, you know, I find litigation, fall in love with it, and take this wicked, you know, left turn, which turned out to be really good. Kind of give me your background and kind of the story of how you got to here.
Sure. Yeah. So I went to college at the University of Missouri and med school as well. I did my residency training at Carolinas Medical Center out in Charlotte, North Carolina.
Yeah.
Was there for 3 years. And then my wife and I moved back and we lived in St. Louis for a couple of years. And I worked at a level 2 trauma center there, and then moved basically back home here. I'm in Southwest Missouri. And worked for 10 years at a level 1 trauma center. I was the medical director and department chair there as well for 5 years. And then I left there to actually started my own emergency department staffing company, and did that for a little over 4 years, staffing regional emergency departments, while also working in a rural critical access hospital for about 5 years. And so basically after about 20 years of practice, just kind of started looking for things that interested me, where I thought I could still contribute, but not necessarily be at the bedside. And I had the pleasure of being involved in a couple medical malpractice cases on the defense side throughout my career. Never really named myself, but had to go through some depositions, and just sort of when you're an ER physician, you're sort of peripherally involved in lots of cases,
because they're coming through your front door. They're coming through your front door.
Right. Yeah. The one I remember the most was a guy that came in with a belly full of blood, was dying in front of me, saved the guy's life, get him to a surgeon. They save his life, and then like way on down the line had some weird complication, and somehow I get pulled into that suit when literally I was there. I was there for I was there for an hour and a half, kind of pulled this guy from, the depths of hell and got involved in it. But, through those processes though, man, I realized during those depositions how non-medical, even good medical malpractice plaintiff and defense attorneys are. I mean, they're around it all the time, but you kind of take for granted the medicine that that they don't. And they might know the terminology and they might know a lot about it, but as far as really how things work, I was taken by how little they really do know. And so, from that, I was like, I think I might be able to help them in some way. And it took me a while to navigate through, different paths to figure out how I can be most helpful. And then I landed on this, and I just absolutely love it. And it's become it's growing and doing so well that I actually was actually able to leave clinical practice entirely a few months back. So now I'm doing this full time and just absolutely love it.
I think that's fantastic, and I often get the, do you miss clinical practice? And quite frankly, part of me really does. At the same time, I really love what I'm doing. It sounds like you love what you're doing, and so it sounds like a good trade-off. Now we emailed each other back and forth a few times before the podcast to kind of come up with an outline, and one of your bullet points I find very intriguing because I really wanted to talk about expert witnesses, expert witness testimony. You see it from both sides with what you do. And your bullet point was interesting. It said, the messed up world of expert witness testimony and the industry around it, which is a very intriguing way to describe it. Could you elaborate on that?
Yeah, sure. So one thing that I didn't mention of what I do with my consulting as well is I help seek out experts and seek out the right expert witnesses for cases. So
That's important.
Yeah, identifying which experts you need,
Yeah.
and then actually finding the right kind of expert, for that case. And I before I got into this consulting, because when I got into this consulting, Bill, it was just all on the medical side. Let me help them understand the medicine, the strengths and weaknesses of their case, how things work, and then I became more involved in the finding of the right experts. And as I've done that, the expert witness world is weird and messed up, right? Because the concept of an expert witness is someone who can opine generally on standard of care,
Yeah.
or causation, or so those are the two bigger areas
Yeah.
in med mal where they focus, right? And on the standard of care, it's so crazy because everybody wants an expert that has a 6-page CV, went to an Ivy League school,
Mhm.
has all of these publications and can speak to all the specific details and are the smartest person in their field. When in reality, when it comes to brass tacks, most of that stuff, I don't honestly believe it means all that much, Bill. Like,
Yeah.
you reach a certain point of this person is an expert in their field, and by that I mean they're boarded, they have a reasonable amount of clinical experience, and they went to a reasonable medical school and training. And I think after that, I really think plaintiff and defense counsel, they need to stop there and find somebody that can talk, find somebody that can educate, find somebody that can explain, and find somebody that believes in the case. And so,
Yeah.
but the world is so messed up in medical experts where everybody's just looking for the guy that looks the best or gal that looks the best on paper. And it's just not,
Well,
it's just not.
yeah, I agree. Yeah, these folks are experts in their field. I think the phrase expert witness is a real misnomer because a lot of these
Sure,
folks,
yeah,
they're
absolutely.
not good witnesses. They're experts, but boy, their communication skills suck, right? And yeah, they may look good on paper, and I totally understand that, and I find that very interesting. So when you're helping your clients find experts, there's and this is a fact. This is something I tell you that's factual because I have tested this repeatedly over the last 20 years. Is that jurors do appreciate an expert witness that's worked on both sides of the aisle, right?
Mhm.
Versus you get the what they call the the whore, the plaintiff whore. I
Right.
hate
Yeah.
to use
Yeah.
that word, but that's actually a term of art, I think, in litigation. When you have an expert witness for the plaintiff that's done 99% plaintiff work versus a different expert, maybe that's 60-40, right? It doesn't have to be 50-50, but at least something uh close. Is that something that you look at when you're looking at getting a
Yeah.
expert
Yeah.
witness?
Yeah. For sure, Bill. And the thing is, in med mal, it's not nearly as difficult to find that mix.
Yeah.
You know, I think in your personal, just your generic personal injury world, I think there are a lot more people that focus just for the plaintiff or just for the defense, um, simply by the nature of their subject matter is so similar in their cases that they would have a hard time using one set of logic for the plaintiff and then having to use a different set
Yeah.
of logic for the defense. But with med mal, it's much easier because the medicine's the medicine, right? Like what
Yeah.
happened is what happened, and it's much easier for a physician just to speak to what happened in that particular case and why the standard was breached or not. So
Yeah.
I've found very few, gosh, if any, straight plaintiff med mal physicians. Now there are some physicians that will just simply say, I'll only provide expert witness testimony for the defense. I refuse to testify against a doctor. And I don't like to work with those folks either,
Yeah.
on either side.
Sure.
Because if all you're doing is looking for a way to defend the doctor, I don't think that makes you very effective. Um,
That makes total sense. Okay, so two
yeah.
other variables I want to run by you because I think this is a very important discussion we're having for our med mal folks because I think there's a lot of myths out there. There's a lot of myths that just aren't true. They may seem true, or there's rumors that they're true that they're not true. And you just mentioned one the whole credentials thing. You know, more is not necessarily better when it comes to actually being a really good expert. Two other factors. First one being local expert versus national expert. Where do you see? Because a lot of attorneys that I talk to, like, well, okay, so I have a case in Orlando, Florida. Well, I could get the number one ER physician expert locally in Central Florida, or I get somebody out of Rush in Chicago, right? A prestigious, bigger hospital, and that may be more influential on the jury. Where do you land on that issue?
I don't. I think you have to balance. You have to balance what you need, right?
Yeah.
I'm more interested in type of facility and venue as rather than actual geography, right? I don't know
Yep.
that geography matters all that much. So take for example. I've worked in a level 1 trauma center, right?
Yep.
I've worked in a rural critical access hospital. I'm an ER physician. Those are two different jobs. It is
Yeah.
not the same,
Yeah.
right?
You're right.
So
Yeah.
level 1 trauma center, you would think would be harder, right? It's not. You have every resource available. You have trauma
Sure.
surgeons, you have cardiologists, you have infectious disease, you have neurology, you have 6 different ER physician colleagues working with you at any given time where you can go ask a question, right?
Yeah.
You're working in rural America, you're by yourself for 24 hours with literally no one around you.
Yeah.
How you practice is entirely different. The decisions you have to make, right?
Yeah.
I don't have ultrasound on the weekends. I don't have, XYZ. Anything that I do, it has to be me, right? So
Yeah.
for me, I would rather find um, a a good expert, regardless of where they are, but a good expert that is familiar working in the type of environment that the physician in question's practice was located. So for me, it's not as much geography, it's more clinical setting because you're
Clinical
trying to
match.
judge you're trying to judge the standard of care against what another reasonable physician
Okay.
in that situation would do, right? So do I want a guy that's been in nothing but academia his
Yeah.
entire life and all he does is teach residents
Yeah.
to opine on the care of a guy working as a single coverage hospitalist in rural America, trying to figure out what to do when it's snowing outside and, has a
Yeah,
septic patient that he can't transfer. Like, no, that's not believable. I don't like it. So
to- to-
find the right person.
totally makes sense. Boy, my next two questions are tough. Hey, listen, I don't mind asking controversial questions on this podcast because I think they do need to be asked because these come up a lot. The first one,
This is the beauty of what I do also, Bill.
yeah,
Everything I do is like work product,
yeah,
non-discoverable.
yeah.
So
So
I also love to give people answers they don't want to hear,
perfect.
but because it helps them.
Yeah, exactly. And I'm in the same boat. I'm a non-testifying expert, so it is what it is. And I need to be brutally honest. Here's another tough question. This comes up a lot on cases. Not that this could be an issue for expert witnesses, but this comes up a lot with defendant witnesses, and I kind of want to get your views on both. The whole D.O versus M.D designation. Now, I know you're an M.D, right?
I am, yeah.
And this is, I see DOs get attacked. Defendant DOs get attacked, and expert witness DOs get attacked by opposing counsel, saying, "Well, you're like DO is the redheaded stepchild of the MD, right?"
Right.
Well, first of all, educate our audiences about the differences, and when it comes to again both defendants and experts, let me know what you think about that topic because this comes up all the time because the DO population of physicians has grown substantially.
Yeah, absolutely. So, I mean, in its most basic sense, it all just depends on where you went to medical school,
Yeah,
right? So you have your allopathic medical schools, your medical doctors, your MDs, and then you have your osteopathic or DO medical schools. Your DO medical schools, in addition to the regular medicine, traditionally taught osteopathic manipulation as part of the curriculum. I think most of them probably still do on some level, but rarely is that a big part of any DO's practice once they get out of medical school anymore. And really, it is just another pathway, a pathway into medicine. So
yeah,
that is in its most basic sense the difference between the two. What has become or what was sort of culturally, that's not the right word, but anyway, people would look at MDs as people going to real medical school and DOs
yeah,
as people going to that couldn't get into regular medical
yeah,
school, but
yeah,
was able to get into this one where they had to pay a lot more money and can
yeah,
still call themselves. It's bullshit, man. It's
yeah,
not. There's nothing there anymore.
yeah,
There's nothing there anymore. And as far as in practice, I mean, I can tell you, I don't know which of my colleagues are MDs or DOs. I never did. I mean, it's
mhm,
once you make it through, once you make it through residency and you're out in practice, from a clinical standpoint, it makes absolutely no difference. So I've not seen it come up, but then again, I don't work so much on the actual trial and deposition side and when people try and bring it up, but I think you're probably going to find as the generations go on, that's going to become less of an issue. And that your older generation and the folks that are sort of heading out of retirement now that had those beliefs of there being such a major difference,
yeah.
I think that's going to go away.
Excellent. Now, how about the difference between, say, what you do, and I know a lot of law firms, both plaintiff and defense, use legal nurse consultants as opposed to, say, an MD, somebody like you, to essentially probably do something similar. Assess cases, help the attorneys understand the medicine. What is the difference there, and does it really matter?
Uh, yeah, I mean, it matters. It's apples and oranges. I mean, so legal nurse consultants they have a huge role. I mean, they do really important work on cases. They're great at putting chronologies together. They're great at summarizing, medical concepts. Um, and I think some of them, particularly the ones that have been in the industry long enough, are really good at picking up good case, bad case, has merit, doesn't have merit, right?
And there may be nursing care. They may be defendants in the case. So yeah,
Entirely.
exactly.
Absolutely. Yeah. I mean, I don't even try and look at the actual nursing care and opine one way or the other. Health.
Sure.
That's I'm not a nurse, right? It's two different professions.
Yeah.
I do feel like at times, though, the nurse consultants are utilized a little bit too much to provide an opinion
That's the
on
issue. That's the
physician
issue.
standard
Yep.
and causation. It's two different professions, Bill.
Yeah.
And nurses are well trained and they do exceptionally well in what they do, but they're not physicians, and they just can't. They don't have the same level of understanding of certain processes and standards of care, and I feel that attorneys that rely solely on their nurse consultants to give them that information are missing out on a lot.
I see some corners being cut there, and whether it be convenience or usually it's cost, right? It's always cost.
Mhm.
It's always follow the
Sure.
money, right? But I've seen it, and I've seen it. I don't do any plaintiff work and MedMal, it's all defense, but I've seen the nurse consultant used to really be evaluating medical issues when it really should be more pigeonholed into the nursing, since they're nurses, just like you would avoid giving any kind of formal feedback either way, probably, with nursing care. Here's another. This is actually my favorite question. This is my favorite question because you work with defense counsel, you work with plaintiffs counsel, and you've been doing this for a while. And again, don't hold back. I want your brutal honesty. When it comes to medical malpractice, what are the major differences you observe between plaintiff attorneys and defense attorneys? Maybe a compare and contrast.
Sorry, my son was trying to call me through the phone when you asked that. Ask me one more time.
But no, that's okay. We all have the kid issues. Since you work with both plaintiff and defense attorneys,
Yeah.
they are very different breeds. Can you maybe give your experience in medical cases, kind of
Oh, sure. Oh, yeah.
a compare and contrast between what you see from defense attorneys, what you see from plaintiff attorneys, and maybe what you'd wish both would do a little bit differently to be
Yeah,
better?
no. Yes, no, that's a cool question. I like that question. So, we'll start with the plaintiff side. So I'm a physician, right? So I grew up in medicine hating plaintiff side attorneys, right? I mean, like all they do is sue doctors, and
Yeah.
it's they're just out to make money. And we get all these throwaway journals as physicians. And in all these throwaway journals, there's always some article about this huge verdict or huge settlement for a plaintiff, and it looks so ridiculous, and why did this ever happen? The more I've actually worked with the plaintiff attorneys, for the most part and on the whole, and really the only ones that I'm even willing to work with are the ones that genuinely that genuinely care about their clients. They really feel like something was done wrong and really feel like they need to get their clients some compensation to help fix the problem. And honestly, I feel like most of, at least the ones that reach out to me and want to know the truth about a case, they tend to fall into that category. Additionally, I find that plaintiffs' attorneys don't, they really only like to go after cases where they really feel like they can win. I've consulted on lots of cases where I'm like, you could pursue this, but it's going to be a challenge. And immediately they're like, no, not going to do it. Like, if this isn't a really strong case, I don't want to do it. And I know it doesn't seem like that on the defense side. On the defense side, you're like, how could they possibly bring this case? It's ridiculous.
Yeah.
But they really, at least the ones I work with, don't pursue cases that don't seem like they have some degree of merit. Now, damages is an entirely different story, and
Sure.
that's but on the defense side, like we mentioned, man, they don't get to choose the cases that come to them, right? Like, Their client's been sued. They have to do everything they can to mitigate the damages. And so they, like, kind of like you said, they sort of dig in their heels, they get their story, and they stick to it. And that's what they have to do.
Yeah.
They don't have a choice. That's why they're retained, right?
Yeah.
That's why they're paid hourly, and that's what they're doing. And I, as a physician, I very much appreciate that.
Yeah.
What I wish could happen, and which will never happen, but part of what I do, and the reason I do it is what would seem most reasonable to me is if this entire system would be gone, and when bad things happened, a group of reasonably minded people could get together and look at what happened and come up with some reasonable compensation to make sure that the injured person's taken care of, and everybody go about their business.
Yeah. Good luck with that, Jeff.
I know, right? Well, then I'd be out of a job too.
Yeah.
So
What
I
am
don't
I
know
gonna?
why
Yeah.
I
What do you want me to do? Yeah. Let's do that in about 20 years. Like when I'm
Perfect.
about to. Yeah. Yeah. Then we'll do
Perfect.
that. But for the next 20 years, let's not really do that.
Perfect. Yeah. And so, I mean, so as far as what I wish they would do differently, given the system that we have, Bill, I don't know if there's a lot that either can do differently.
Yeah, I tell you, so some states, I know Indiana being one of them, and Kentucky started doing this maybe 5 years ago, to try to not necessarily to get what you're talking about, but maybe an intermediate step. They have a medical review board. Have
Yeah.
you heard of it? Yeah, this is
Yeah, those don't
complete
work.
epic political bullshit, right?
Yeah,
It's like,
those
yeah,
don't
so
work.
you have okay, so you have a case against the emergency room physician. So we're going to send it to 3 emergency room physicians. Oh, by the way, that all compete with each other and the defendant. And we're going to run the case by them, and they're going to vote on it to determine whether the this is before a trial. And then, oh, by the way, those results are discoverable to jurors. Have you heard much about that process? I'm not sure if Missouri.
I've heard enough about it to know that
That
it's just another step to slow the process of what's going to happen
it's
anyway.
terrible.
Yeah.
It's absolutely terrible. Well, those are really good insights. Again, I find this to be a fascinating conversation. Let's wrap this up with kind of the last thing here on the outline is you described it as yeah, your biggest fears and concerns for medicine over the next decade. Things are moving fast, and I know what mine is. I know what my fear is, and you can address this as well. It could be overlapping with some of your fears. My fear is artificial intelligence, and how that's used in medicine and how that will affect litigation. I know there's some other things. I know a lot of people are worried about, how COVID perhaps, where it actually came from, how it was used politically as a weapon. Were these vaccines? Now, I mean, you still got a lot of angry people here, and not a lot of answers. And is that going to happen again? At a very convenient time, like the last timing of this was, you have a lot of, I think someone like you and the medical community, you have your fears. I think society has a different set, but maybe even overlapping fears. I have my fears. Next decade, what are the top maybe 2 or 3 fears or worries or concerns that you have as a physician?
Yeah. So my biggest fear, and maybe I'm contributing to it by having left the bedside, is that, so medicine's an art, right? So
Yeah.
yes, there's science to it, but medicine's an art, and you learn that art from the people that did it before you, and you look to your colleagues, and you look to people that have been practicing for 20, 30, 40 years. You learn things from them, and you grow and you grow. And after 15 or 20 years, that's about the prime of where you're probably your best, right?
Yep.
Physicians aren't practicing that long anymore.
Yeah.
The challenges of medicine, the finances of medicine,
Yeah.
Private equity buying up all the healthcare and all
It's
the
a
healthcare
business.
facilities. It is.
Listen, this is a business, and many plaintiff attorneys, rightfully so, get in front of a jury going, it's profits over safety. And here's the thing, they're largely right. It's a big time business. And
Massive.
and by the way, I've worked with thousands of physicians, many of them that are retired that have a pending suit. So we're preparing for dep or trial. And they told me, I'm so glad to not be in this horrible system anymore because patient care like wasn't my focus anymore. As all this financial and political
Right.
bullshit I was dealing with. And I think that's kind of what you're saying too, is we're losing good physicians because the system sucks.
Right. And so here's the deal, man. Nature abhors a vacuum, right?
Yeah.
So if you're losing physicians and your best and brightest probably aren't going to choose to go into the medical field because this is all out in the world now. This is all out in public. Physicians aren't hiding this anymore, right? Everybody's out there saying this sucks, it's terrible, I don't want to do this anymore. And so your best and brightest aren't going into healthcare, right?
Yeah.
But nature abhors a vacuum. Something's going to fill that void, right? Your biggest concern is that AI is going to fill that void, or at least, because something's going to have to fill it, right? We're going to have to be more efficient.
Yeah.
The demand for healthcare is not going down.
No.
Right. So something's going to fill it. Right now, what we're filling it with is advanced practice providers, right? We're filling it with PAs and nurse practitioners, which are fantastic and they're great. And there's some that are amazing, right? But we're churning out all of these advanced practice providers at a rate like you've never seen. I mean,
Yeah.
the number of programs and the number of people graduating from these programs, because there's a void, there's a need,
Yeah.
right? But the issue is that society is really starting to equate the healthcare provided by this level of education, this level of training, with that of a physician level of training.
It's different.
Right. And so you throw that into the med mal world.
Yeah.
Nobody's knowing how. It's an elephant in the room right now that people aren't talking about that much.
Yeah. Oh, nobody. No one's talking about that.
No, like, and it's there. I mean, I was on a call with a client this morning, and it was clear that the PA was doing most of the work throughout the hospital stay, and that the attending was just signing off on this, right? But it's the attending that's getting sued. But you really don't know who's providing the care. And that's going to happen more and more and more. And it's really degrading the healthcare system overall. And something's going to fill the void. And super high quality physicians that are well trained that's not who's going to fill the void. So I don't know how we get out of the death spiral, but it's definitely scary to me.
Yeah. That's brutal. There's things change and things change rapidly. And so we'll stay on top of that, see how it affects litigation. But it's been a pleasure having you on the show. Thank you so much. I have your website right up here. I want to give our audience your information. It's On Call Med Legal Consulting, and that is ocmedlegal.com. And what's the best way to get a hold of you if we have a plaintiff or a defense attorney that may want to talk to you, or may even want to retain you to do some of these things that you talked about?
Yeah, so they can reach me at jeff@ocmedlegal.com. I'm also really active on LinkedIn. I write on LinkedIn every day.
Yes, you are. You're on LinkedIn every day, and I see you every day, and I try to like as much of your stuff as I see. It's great
Yeah,
stuff.
I appreciate that. Yeah, and I write generically about some of the cases I consult on, trying to educate, talk about the expert witness world and various other things. But yeah, connecting with me on LinkedIn is a great way as well. But jeff@ocmedlegal.com is the quickest way to get a hold of me.
Outstanding, Jeff. Thank you for so much. I mean, what a fascinating discussion. Would love to have you back on in the future. But thank you so much for being on the show. And to our audience, hope you're enjoying this MedMal series brought to you by the litigation psychology podcast. I almost forgot the name of the damn podcast. Yeah, I'm my head's spinning. I need more caffeine. Litigation Psychology Podcast, brought to you by Courtroom Sciences. Thank you, everybody, for participating. We'll see you next time.